I'm Dr. Ajibola. We want to continue our cardiovascular system series, and in this video we'll be talking about ventricular outflow tract formation and defects. So let's start. Septation of Truncus arteriosus and bulbous codis. This diagram, we want to see here we have our right ventricle and we have our left ventricle. We also have our right atrium, left atrium, and then dividing the right ventricle from the left ventricle, we have our muscular intraventricular septum, and then the outflow of both the ventricle is our Truncus arteriosus. And we also have our bulbous codis here, which is going to form the smooth part of the right and the left ventricle. So our goal here is to divide the Truncus arteriosus into two so that we can have the aorta coming out from the left ventricle and the pulmonary trunk coming out from the right ventricle. Looking at the next picture, we want to see here that the neural crest cell is going to migrate into the Truncus arteriosus, and once the neural crest cells migrate into the Truncus arteriosus, that is going to lead to the development of aorticopulmonary septum, right? Which is what we see here. So you can see the aorticopulmonary septum being formed and dividing the Truncus arteriosus into two. If you look at the next picture, the aorticopulmonary septum is going to spiral so that the pulmonary trunk is going to be coming out from the right ventricle and the aorta is going to be coming out from the left ventricle. And if there's a failure to spiral, so that means the pulmonary trunk is going to be coming out from the left ventricle and the aorta is going to be coming out from the right ventricle. So the neural crest cell migrates into the trunca and the bulbar ridge, which grow and spiral and then fuse to form the aorticopulmonary septum, and that's what we refer to as septation. In the next slide, the aorticopulmonary septum divides the Truncus arteriosus into the aorta and pulmonary trunk. Remember that aorticopulmonary septum is also involved in the formation of the ventricular membranous septum. On the next slide, if there's any defects in the development of the aorticopulmonary septum, which normally due to failure of neural crest cell migration into the Truncus arteriosus, normally present as early cyanosis because of the right to left shunting of blood. Remember, on the right we normally have the deoxygenated blood that normally supposed to go to the lungs for oxygenation, then return back to the left side. But in this particular defect is normally right to left shunting of blood. So that means we are shunting the deoxygenated blood from the right side of the heart to the left side of the heart, so thereby causing early cyanosis. And this is normally associated with the George syndrome, which is deletion on chromosome 22. So let's talk about the defects that are associated with ventricular outflow tract formation. The first one we'll be talking about is Tetralogy of Fallot. Tetralogy of Fallot. This is the most common early cyanotic congenital heart disease, and the onset of cyanosis usually occurs after 3 months of age. And this is a right to left shunting of blood. And then what's the major problem here? This is due to abnormal neural crest cell migration, and this leads to misalignment of the aorticopulmonary septum, leading to anterior superior displacement of the septum. And there are 4 defects that we see as a result of this misalignment. So if we look at this diagram, we can see that the aorticopulmonary septum, right, has been moved anteriorly and it also has been displaced superiorly. So because of that, there is stenosis of the pulmonary infundibulum. So you can see that there is stenosis of the pulmonary trunk, and then also the aorta now is more wider, and it looks as if it's receiving blood from both the right ventricle and the left ventricle. And then because of the superior displacement of the aorticopulmonary septum, there's also going to be a problem. This is going to pose a problem in the formation of the membranous part of the interventricular septum, so thereby leading to another defect, which is ventricular septal defect. And then because of the pulmonary stenosis, the pulmonary infundibulum stenosis, the pressure in the pulmonary artery is going to be increased, right? And because of that, so that means the right ventricle needs to increase its pressure so that it can push the blood through the pulmonary what? Through the pulmonary artery. And because of that, now that's going to lead to growth alteration in the right ventricle, and that's going to lead to right ventricular what? Hypertrophy. And as the pressure in the right ventricle is increasing, once you get to a point whereby the pressure on the right side is more than the pressure on the left side, then the deoxygenated blood is going to be shunting to the what? To the left side. And as deoxygenated blood is moving from the right ventricle to the left ventricle and then go to through the aorta, and this is going to produce cyanosis in this patient. So what are the 4 things that we want to see from this defect? So number 1, we want to have our pulmonary infundibulum stenosis. Number 2, we can see here we have the overriding of the aorta. Number 3, we have the ventricular septal defect. And lastly, we have the right ventricular what? Hypertrophy. So looking at the next slide, 4 defects in this patient. 1, pulmonary infundibulum stenosis, and this determines the severity of Tetralogy of Fallot. Very important. So what determines the severity of Tetralogy of Fallot is how stenosed the pulmonary infundibulum is. So the more stenosis you have, the more severe the condition is to be. And number 2, we have the overriding of the aorta, meaning that the aorta is receiving blood from both the right and the left ventricle. We also have the ventricular septal defect. So the membranous intravascular septal defect because of superior displacement of the aorticopulmonary septum. And then remember, aorticopulmonary septum involves in the formation of the membranous part of the intravascular septum. And then lastly, right ventricular hypertrophy. And then this is due to the pulmonary what? Stenosis. What are the clinical findings that we can see in patients with Tetralogy of Fallot? Number 1, arch systolic crescendo decrescendo murmur. And then this is due to the pulmonary what? Stenosis. And then number 2, they want to have decrease in oxygen saturation in the left ventricle and also the aorta. Because if you look at the diagram, you can see that there's shunting of deoxygenated blood from the right ventricle into the left ventricle. So thereby decreasing the oxygen saturation in the left ventricle, and also that's going to lead to decrease in oxygen saturation in the aorta. This patient, they can also have what we call the teeth spell or hypoxic spell. This is due to sudden increase in hypoxemia and cyanosis due to events that exacerbate right outflow obstruction, an event like crying, fever, exercise. So any of these events can further worsen the pulmonary stenosis, right? So thereby making the what's called increasing the pressure in the pulmonary artery, and that's also going to further increase the pressure in the right ventricle, thereby leading to more deoxygenated blood being shunted to the left ventricle, and the more deoxygenated blood will be leaving through the aorta, and thereby worsening their cyanosis. And in this patient, they actually learn to squat, right? And how is squatting going to help them? By doing squatting, that actually increase the systemic vascular resistance. So squatting increases the systemic vascular resistance, or you can call it total peripheral resistance. And what's this resistance going to do? So by increasing the systemic vascular resistance, right, in the artery, that is going to increase the pressure in the aorta, right? And as we increase the pressure in the aorta, the left ventricle needs to increase its pressure so that it can push the blood through the aorta. So that also going to lead to increase in the pressure in the left ventricle, thereby decreasing the right to left shunting of blood, right? So that more blood can go into the pulmonary system for oxygenation, and more oxygenated blood can return to the left side of the heart and can leave through the aorta, right? So that's what we call that's how squatting actually helps those people. So by increasing the systemic vascular resistance, which leads to increase in afterload, and a decrease the right to left shunting of blood, and this leads to increased pulmonary blood flow for oxygenation in the lungs and improves their cyanosis. So how do we make the diagnosis? So on the chest X-ray, you want to see what they call the bull-shaped heart. And the bull-shaped heart is due to the right ventricular hypertrophy. And also when you look at the chest x-ray, this patient they want to have decreased pulmonary marking because of decreased pulmonary blood flow. And also you can also do echocardiogram in this patient. You can also do cardiac catheterization in this patient. And the treatment, definitely you need to maintain the shunt. You want to keep the ductus arteriosus open, so you need to give them prostaglandin. Also oxygen can also be beneficial in this patient. Need to chest positioning during cyanotic episode, right? Remember, by positioning, so you are trying to also then relieve the sinuses, and a surgical correction. Next is persistent truncus arteriosus. Persistent truncus arteriosus. This is another cause of early cyanosis, and this also in this patient we see right to left shunting of blood. And this abnormal neural crest migration, which lead to failure of septation. So the main problem in this patient is failure of what? Septation. So it's a failure in dividing the truncus arteriosus into two. And because of that, so that leads to persistent truncus arteriosus, meaning that we have one outlet from both ventricle, right? So one outlet receiving blood from both the right ventricle and the left ventricle, right? And in this patient, obviously, remember we said that the aorticopulmonary septum also helps to form the membranous interventricular septum. So that means if you are not forming the aorticopulmonary septum, so that means there will be no membranous septum. So this can also lead to VSD, which is membranous septum defect. And what are the clinical findings that we see in this patient? So definitely they want to have cyanosis at birth, dyspnea, fatigue, failure to thrive, harsh systolic murmur at lower sternal border, and on chest x-ray we want to see absence of pulmonary artery, also large aorta arching to the right side, and the treatment is surgery. And the last defect we'll be talking about is transposition of great vessels. Transposition of great vessels. So this is when the aorticopulmonary septum fails to spiral. So this is a problem with failure of the aorticopulmonary septum to spiral. And the aorta originates from the right ventricle, and pulmonary artery originates from the from the left ventricle. Like I said, this is a problem with with spiraling. And this associated with infant of diabetic mother. So this associated with infant of diabetic mother, and this is not compatible with life unless all shunts are present, like the VSD, the PDA, the patent ductus arteriosus. And if you're looking at this picture, remember normally the aorta normally comes out from the left ventricle, and the pulmonary artery normally comes out from the right ventricle. But because of failure to spiral, the aorta now is now coming from the right ventricle, and the pulmonary artery is now attached to the left ventricle. So in this condition, the type of blood that want to be coming out through the aorta is deoxygenated blood. So that means deoxygenated blood is what is going to be going to the systemic circulation. So this is actually a very, very severe condition. So without surgical intervention, this patient they want to die. So they need surgery. On the next slide, what are the clinical findings? So cyanosis after birth and a worsening as the PDA closes. And then on chest x-ray, we want to see abnormal pulmonary marking, and also we can also do echocardiogram to make the diagnosis. And the treatment is just to give them prostaglandin to keep the ductus arteriosus open, and then they need surgery. Thank you guys for watching my video, and don't forget to subscribe to my channel for more videos.